Okay, great, fantastic. Well, I'm just overjoyed. I talked to Tom already and thanked him for inviting me. When I get an invitation from him and PHEN, it's one of those ones that I really try to prioritize because of all the work that is being done to educate men about prostate cancer. And it's been a sustained effort over 20 years. So congratulations to Tom and PHEN and the whole group. So today I'm going to talk about prostate cancer and active surveillance in Black men. And the real question is, it's safe to consider. So a little bit about active surveillance. Active surveillance is a management strategy that is predicated on the belief that the existing disease that is identified is clinically insignificant. And we've heard a number of presenters use this word, clinically insignificant. That prostate cancer progression is a slow, stepwise process, and that the disease, if it progresses, may be reliably captured during surveillance. And if captured, the intervention, though delayed, may still be applied with curative intent. So those are the considerations of active surveillance. And that is different than watchful waiting, where the intent of a treatment is to address symptoms that a patient may be having from a cancer, and the intervention at that time may or may not be curative. So active surveillance really represents a contract between the patient and physician that we are going to follow your cancer that we think is clinically insignificant at this time, and that if and when it presents, we can still cure you with definitive treatment. So the rationale for active surveillance comes from several different trials. And I don't have time to show the data on all of these trials, but we've used the concept of low risk and Gleason score 6, and we're going to go a little bit more into depth on this. But what we have seen is that in randomized clinical trials, active surveillance or observation of low-risk prostate cancer has not been associated with increased mortality at 10 years, with a historical trial that we call PIVOT and a more recent trial called the DETECT trial, where men with screen-detected low-risk cancer were observed at 10 to 15 years, and there was no difference in survival whether they went on active surveillance, had radical prostatectomy, or radiation. Now, it is important to remember, although there wasn't a survival difference, treatment did decrease the future spread of cancer. So that tells us that we have to continue to follow those patients. But at 10 and 15 years, there was no change in mortality. Now, this is important because that means that if I have this low-risk cancer and I can avoid treatment for some period of time, that means I get to avoid or delay treatment-related side effects, incontinence, erectile dysfunction, things of that nature. We also know that as a rationale for active surveillance, we have newer tools, some of them are molecularly based markers that can help us stratify the risk of men for progression or upgrading of cancer based on the molecular profile. And a couple of these have been mentioned already: Polaris, Oncotype DX, and Decipher. And we also have multi-parametric MRI, which has been mentioned before, which has really helped to revolutionize our visualization of the prostate and being able to target an area for a very specific biopsy. And I'll show you some data, or at least one study on long-term data that shows that this strategy is certainly supported in the literature. And in fact, active surveillance really has become standard at this point in time. When we look at several of the different guidelines panel, whether it be the European Association of Urology, American Urologic Association, the UK Guidelines Panel, or the NCCN, there has certainly been a consensus about what the candidates for active surveillance should look like. They should be individuals who have a life expectancy greater than 10 years. If they don't have a life expectancy greater than 10 years, and we think they're going to die of something else, then perhaps what we're talking about really in those patients is watchful waiting and not active surveillance. So active surveillance candidates are healthier individuals. They have, in general, low-grade disease, that's Gleason score 6, often now called grade group 1, low volume disease, grade group 1, and in some cases, grade group 2, Gleason score 7, with a very low percentage of the 4 component and a low number of cores. When we do a rectal exam, their disease is either non-palpable or they have a small nodule. And now MRI is recommended by at least 2 of the panels, the EAU and the UK panel, and is optional at baseline with the AUA and NCCN panels, although in follow-up, they would recommend that MRI as a part of the surveillance strategy for men on active surveillance. So this is becoming standard. Now, one study that supports this is by Dr. Klotz, who was one of the first pioneers who really championed this concept. And he presented his long-term data several years ago on about 1,000 men with low risk to favorable intermediate risk prostate cancer who were followed. And these men were followed with PSA testing, physical exams, seeing them on an intermittent basis. And intervention only occurred if the PSA began to increase rapidly, if on the subsequent biopsy, Gleason score increased, or if there was clinical evidence of progression. The median follow-up of the group was about 6 years. And when they looked over time, only about 15% of the men starting out died, and only 1% of the men died of prostate cancer, and only 1% of the men developed metastatic disease. And when we looked at the benefit to the men who remained on active surveillance, 60% of the men were still on active surveillance at 10 years, and over half were still on active surveillance at 15 years. So this looked like a very reasonable strategy and has been reproduced in other studies as well. Now, we do know that most of the men in their studies were Caucasians. We also see that with the U.S. Preventive Services Task Force recommendation in 2012 of giving a D recommendation, we really were hit in the mouth, should I say, punched in the mouth with these data showing that we were diagnosing a lot of low-risk prostate cancer. We're having data showing us that these low-risk cancers may not pose a risk of death, and active surveillance is something that we should consider. And so active surveillance has increased dramatically. This is data from the American Urologic Association Quality Assurance, or AQUA database. Over 1,945 urologists, over 8.5 million patients data in here. This is an electronic health record that urologists enter to really get information about quality improvement, enter this kind of data into a national registry. And so a lot of urologists are involved in this database. And so they wanted to see what the uptake of active surveillance was over time. And so there are over 20,000 men with low-risk prostate cancer in this database where the treatment management was specified. Median age of the group was 65. And the active surveillance group in this population is this blue bar right here. And you can see that from 2014 to 2021, active surveillance increased from 26% at baseline to almost 60%. That's a huge increase. And I am really proud of the Urologic Association for embracing this type of management of low-risk cancer. One thing we can say, though, there is heterogeneity of the uptake of active surveillance, both at the practice level. It varied between 4 to 78% of practices, and it varied at the practitioner level from 0 to 100% of the practitioners, which shows us that there are still educational opportunities available. Now, the importance of active surveillance we can see, but there are some things that we know about prostate cancer in Black men that have certainly caused us to pause about whether this should be used or is an appropriate tool for African American or men of African descent who are diagnosed with prostate cancer. We know that the disease starts about 5 years earlier. We know, and I will show you data, that Black men at the time of diagnosis may have a higher tumor volume. Historically, what we saw was that there was an increased incidence of metastasis at presentation, which is changing over time. We also know at the DNA, RNA, and protein level, there are clearly biologic correlates of aggressive prostate cancer seen in prostate cancer from Black men compared to those of Caucasian men. Now, when we look at the pathology level, this is a study out of Johns Hopkins. One of my former fellows, Deb Sunday, did this study, and it parallels data from our own center. They looked at the prostates of white men and Black men who would have been candidates for active surveillance and looked at the cancer characteristics of men who were identified as having low-risk cancer. These are men with Gleason score 6 cancers who would have been candidates for active surveillance had they chosen that, but instead they chose radical prostatectomy. So we get to see what was inside the prostate in these men. When we look at tumor volume, white compared to Black, tumor volume in the Black men who would have been candidates for active surveillance was 2 times that of the white men. We see an increased incidence of multiple tumor nodules, an increased incidence of increased size of the dominant tumor nodule. The other thing that Deb noted, which we also have seen, is the distribution of tumors. Prostate cancer characteristically starts out in what we call the peripheral zone, or the posterior edge against the rectum, and not as much in the anterior zone. It certainly can occur there, but is not as common. And what we see on this side are the prostates of Black men compared to the prostates of white men. And what you see in both men, tumors are noted in both zones, both the peripheral and what we call this anterior or transition zone. But interestingly enough, in the prostates of Black men, the prevalence of this anterior tumor, which may not be detected on a routine biopsy, was much higher in the Black men. And in the Black men whose tumors were upgraded after surgery and found actually to be a higher grade, they found that the tumor distribution in the Black men was heavily weighted toward the transition zone compared to the white men. And this speaks to the value of being able to image this anterior zone and the value potentially for MRI. Now, what has actually happened with Black men and active surveillance? When we look at population-based data in the SEER database, so SEER is a nationwide database. They get data from a number of different areas around the country, and they looked at patterns of care for localized prostate cancer in 50,000 individuals from 2010 to 2015. And about 15% of these men were Black, but the majority were white. They looked at men with low-risk prostate criteria. Again, low volume, generally Gleason score 6, PSA under 10, and they wanted to determine what the patterns of care was. Now, in this graph over here, we see the dotted and the dashed lines are definitive treatment, being either radical prostatectomy or radiation. And we see over time, we see in both Black and white men, definitive treatment with radical prostatectomy and radiation decreased over time. With respect to active surveillance, mirroring the AQUA database, we saw a dramatic increase in active surveillance for both Black men and white men. The Black men are in blue, the white men are in the yellow. What we see is although active surveillance increased in both groups, it increased to a lesser extent in African men or men of African descent. So it says that over time, active surveillance is increasingly used for low-risk prostate cancer, but it's less often used for Black men. When we look at curves or odds ratios, the relative likelihood of receiving active surveillance, and these plots are adjusted for a number of different variables, we see that even by 2015, the likelihood of a Black man having active surveillance was less than a white man, even adjusted for things like socioeconomic status and things like that. And the questions are, why is that? It is likely that it may be due to, again, what we know about the earlier age of onset, the potential for differences in biology of the disease. And so the question is that justified? Or is active surveillance safe for Black men? And this is a very important issue, because we know that as we screen more men, we're going to be diagnosing and finding more low-risk cancers. And should a Black man be told that he is not a candidate for active surveillance or not? So there is some data on this available. This is data that comes from the Veterans Administration healthcare system. So the VA is an equal access care system, as long as you meet the criteria of being a veteran. So you have equal access to care and opportunity to be treated in a very similar fashion. And they looked at patterns of care from 2001 to 2015 for men with localized prostate cancer. And so this is what we call a retrospective look. So that means they looked backwards and asked what happened. There were about 2,200 Black men, and there were over 6,000 white men. They looked at what happened with men who had low-risk prostate cancer, meeting our definition. And because there wasn't a specific protocol in place, they deemed active surveillance as those men who had no treatment within 1 year of diagnosis and then had a subsequent biopsy after their diagnosis down the line. So this would be potentially a correlate of patients being managed with active surveillance. The study endpoints were disease progression, definitive therapy, metastasis, prostate cancer mortality, meaning death from prostate cancer, or all-cause mortality. And they followed the men for over almost about 8 years, median follow-ups. That means some were followed for longer, some were followed for shorter. When they compared the Black and the white cohort, what they found was the Black men were younger age, they were less educated, tended to be of lower income, also tended to be of lower clinical stage, but had higher comorbidities, diabetes, hypertension, things like that. When we looked at other things, we saw that there was similar data with respect to the number of PSA tests over time, time to a second biopsy, follow-up time, and men with long-term follow-up, suggesting that the Black and white men had very similar patterns of care. What did we find in this study? Well, first of all, let's look at the likelihood that the disease is going to progress over time. When we look at progression over time, the dark curve is the African-American men, the orange curve is the white men. Disease progression, almost 60% of Black men over 10 years progressed. Only about 48% of white men over the same time period progressed. Again, same management strategies. When we look at receipt of definitive therapy, needing to move forward onto radiation or radical prostatectomy, 55% of Black men, 41% of white men. So this suggests that over time, men initially placed on active surveillance, Black men had a higher rate of needing to move forward into a definitive treatment due to progression of disease. But when we look at some hard endpoints, did they develop spread of prostate cancer? The answer is the risk of spread of prostate cancer was only about 1%, and it was the same for Black men and white men. When we look at prostate cancer mortality, again, about 1% for both cohorts, same for Black men and white men. And what about all-cause death? Death from all causes. Again, about 20% and the same for Black men and white men. So what we see is in this equal access care system, although Black men will progress at a higher rate, they can be salvaged and they don't develop metastasis at a higher rate or die from prostate cancer or other causes at any higher rate than white men, suggesting that if active surveillance is performed in a standard fashion, that it is a feasible strategy. Now, that's a retrospective study, meaning they're looking back. Let's look at a prospective study that was carried out. This is a study that was carried out on the Caribbean island of Guadeloupe. This is a French colony, and 90%, over 90% of the inhabitants are of West African ancestry. There were 234 patients in the study. They had an active surveillance protocol put in place. These men had low-risk disease only from 2005 to 2008. And then after 2008, they broadened it to include men with favorable intermediate risk disease. That means some Gleason 7 with low volume disease. Overall, most of the men had low risk or very low risk prostate cancer, over 80%. What was their pathway? Well, after confirming patients suitable, confirmatory biopsy at less than 12 months, that's very good because it confirms what the original grade or stage was or doesn't, and those men go on to treatment. 62% of the men had MRIs, and they had surveillance biopsies down the stream at 2 to 4 years. This is consistent with current guidelines for how men are monitored on active surveillance. Progression criteria were grade or volume of disease, and at the time of the writing, the follow-up was 4 years. Well, what did they observe in terms of some of the hard endpoints? With respect to death, only 4 men died, and none of the deaths was prostate cancer related. One man who went on to radical prostatectomy had pelvic lymph node metastasis, but there was no patient that died of prostate cancer during the period of observation. Now let's look at what the VA looked at with respect to progression events. At 5 years, about half of the men were remaining on active surveillance, and about half of the men came off active surveillance. At 10 years, only 40% of the men were still on active surveillance, which likely meant that about 60% had progressed. So this data is actually very similar to the VA data. Now, when we look at comparable data, similar data in white populations like the CLOTS data or Tessoyan data, at 5 years, 63 to 75% were still on active surveillance, only 50% here. At 10 years, 64% still on active surveillance, only 40% here. Why did these men come off active surveillance? Most of the time, it was due to tumor considerations and not due to patient anxiety or things of that nature. Now, importantly, not shown here, when the men came off active surveillance, they were very likely to be treated with curative intent. And in fact, the organ confined rate was over 90% in men who underwent radical prostatectomy. So in conclusion, is prostate cancer safe in African Americans? And I'll say it can be. It certainly depends. I think if your life expectancy is less than 10 years, you are certainly a candidate for surveillance. No study has shown that in men with a life expectancy less than 10 years, that definitive treatment will benefit you. So in that situation, yes. What about in healthy candidates? Certainly, we've seen with the data from the VA and from the study from Guadalupe, certainly very feasible in low risk, very low risk, and perhaps some men with favorable intermediate risk disease. All again, there's not a lot of data in there. It does, I believe, warrant an informed discussion with patients, letting them know that for Black men, there's about a 50% chance that disease will progress at 5 years and they may need to come off. And there's a 60% chance that disease may progress at 10 years. Our task is really making active surveillance safe. And this occurs on the part of the physician and the patient. We have to select patients. Best data comes in men with low risk disease, grade group 1, PSA density less than 0.15, and that's an important factor for African American men. MRI must be widely available and used liberally, I believe, because especially in Black men where we can see this distribution difference of tumors in the transition or anterior area. Early confirmatory biopsies, certainly if an MRI wasn't done initially, getting one later, and then using that to decide on the confirmatory biopsy strategy. And importantly, there must be a commitment to guideline-based follow-up by the patient and physician. And the reason I say this is in the non-protocol setting, in community practice, only about 13 to 30% of patients and physicians are compliant with true guideline-based follow-up. And that's where you can fall through the cracks. And that's where, in a population of patients who might be at higher risk of progression, active surveillance could be dangerous. And we don't want it to be that way. So for patients, I would say you want to take control. Knowledge is power. For patients, I would ask my physician, do I meet guideline-based criteria for active surveillance based on PSA, based on Gleason score, based on the number of positive cores, based on my clinical stage? What about MRI? If one wasn't done at baseline, I certainly would have it done within 12 months. And then ask your physician, what is the plan for follow-up assessments and biopsy? And I think with a contract between you and your physician with your specific details and paying attention to the tools we have, active surveillance can be appropriate for the well-selected Black men with prostate cancer. And I'll stop there.
Curtis, that was an incredible presentation, chock full of all kinds of information that we can use. I wonder if one of the reasons for that non-compliance bit has to do with some of the guys' fears of going back and getting a second biopsy, and if there's any moves afoot to make that process a bit easier on the guys.
Well, you're certainly that could certainly be a component. There's no doubt about it. Nobody likes to have a biopsy. MRI is good, but MRI is not perfect. And so all of our guidelines do recommend a surveillance biopsy at this point in time. And, you know, a biopsy is a good way to just assure that things aren't changing.